So that's the frontal outflow tract is medial to the uncinate. Look at that. That's the uncinate attaching to the lamina papyracea, and this is the frontal outflow tract. See, that's the uncinate attaching to the lamina, and this is the frontal outflow tract. First of all, I want you to see how narrow it is, and second, see how close to the middle turbinate it is, how close to the lateral lamella of the middle turbinate it is. Okay, it's not close to the orbit; it's closer to the middle turbinate. So this is the outflow tract, and this space which is formed inside the uncinate over here is the recessus terminalis. So when I was learning first, everything looked like the frontal sinus to us. The frontal recess looked like a frontal sinus, the supraorbital cell looked like, the suprabular recess looked, everything looked like the frontal sinus. Ye frontal sinus, O frontal, everything was the frontal sinus. So remember that you can get a recessus terminalis, which is a blind pouch, but the frontal sinus outflow tract is medial, 80% of times medial to the uncinate, between the uncinate and the middle turbinate, and close to the middle turbinate. Now I want you to remember this fact because this has a very big bearing on surgery. Okay, how the surgery will go. In fact, all these facts, what we are talking about, are actually, we're going to put them all together when this, whatever information we are gathering together, we're going to put it together for surgery. Okay, how each of these facts impacts surgery. And then of course you can have it attached to the skull base like this. So this is attached to the skull base, this is attached to the middle turbinate on either side. And if it is attached to the skull base or middle turbinate, as in 20% of times, then the frontal outflow tract is lateral to the uncinate. Lateral. But this happens only in 2 out of 10 cases. So now we've discussed the agonizing cell as well as the uncinate process. Now we need to know what is the relationship between the agonizing cell and the uncinate. Okay. Now I'm going to show you something. Okay, I'm not drawing everything, I'm just drawing the bulla. Let's suppose this is the bulla, and behind the bulla is the ground lamella. Right? So if the ground lamella is separate from the bulla, then you get a retrobullar recess. Right? If the bulla is separate from the skull base, you get a suprabullar recess. And then if both are there, then you get the hiatus semilunaris superioris and the lateral sinus. Okay? But more importantly, what I'm talking about right now is not the skull base or thing. I'm just talking about the fact that there can be a space between the bulla and the ground lamella. But sometimes there is no retrobullar recess, and the posterior wall of the bulla is the same or is fused to the ground lamella. Can you understand that? So when you go through the posterior wall of the ground bulla, you are already gone beyond the ground. This happens quite often, right? So this is what we do. Now the similar thing happens with the agar and the uncinate. And that is, we know that the agonizing cell is anterior here. And we know that the uncinate lies behind it. So there are times when the uncinate is separate and the agonizing cell is separate. And therefore, when you go through the anterior wall of the agonizing cell, you're in the frontal recess. And then you go through the posterior wall of the agonizing cell, and then you will see the uncinate. Okay? That can happen. But sometimes that is not what is there. You see from there, what I'm drawing, is that there is an agonizing cell, and the posterior wall of the agonizing cell is fused with the uncinate. And therefore, there's no space between them. So when you go through the agonizing cell, and you go through the posterior wall of the agonizing cell, you already removed the upper part of the uncinate. Is that clear?
Yes, ma'am.
So that's what we are going to talk about just now.
But in this condition,
Yeah.
when we are removing the vertical part of the uncinate process by using ball cord,
Yeah.
through cutting,
Yeah.
it might be possible that we are like also damaging the posterior wall of the heart.
Yeah, so what you're doing is when you're removing the, so first of all, if there's an agonizing cell, go through posterior wall of the agonizing cell, yes, there's a chance that you're actually going through the unslit also. So that is what you need to know, ki when you're removing the cell, and if you don't see an unslit, that's because both of them were fused, and when you remove the posterior wall of the agonizing, you also remove the upper part of it. Does that make sense? So there will be times when you will remove the posterior wall of the agonizing and you'll see the unslit. But there will be times when you remove the posterior wall of the agonizing and you'll not see the unslit. Okay? Now does that make sense?
Or we will take it out from the CT scan?
Yes, in sagittal sections. In sagittal sections. So what I'm saying is, sometimes the agonizing cell is there before the middle terminate comes. Then you get the middle terminate, and then you get an unslit which is separate from the agonizing cell. Sometimes it can happen that you have the agonizing cell, and then the unslit is fused with the unslit fused with the posterior wall of the agonizing cell. Sometimes it can happen is that above the agonizing cell there are multiple cells, and the unslit attachment is pushed higher onto the lamina preparation because of those cells. And sometimes you can have a very large agar cell, and then the unslit is pushed onto the middle term. So these are all the different permutation combinations that you can get. Just remember one thing, that the agar and the unslit may be fused, and so when you remove the posterior wall of the agar, you may not see the unslit. So you should be aware that it can happen like that, and therefore you may not see the unslit. Okay, that is in a trans-agar approach. Yes. Yeah, so I'm going to show you. I'll show you how the frontal sinus does not necessarily mean every time that you will remove the upper part of the unslit. We'll come to that. I'll show you.
Another thing is, there is very free line unslit in the
Free lying unslit? No.
attached to the
No, it will not be attached to the upper side. It will be attached to the lamina. It will always be attached. It will always be attached. And like I said, 8 out of 10 times it will be attached to the lamina. So if you follow the unsnap, you'll see that it turns and attaches to the lamina. Okay? And 2 times out of 10 it will attach straight to the skull. Okay? Now we'll talk about the concept of what is the suprabular recess and supraorbital cell. Okay? So, if the bulla reaches the skull base, then there is no suprabular recess. But if it doesn't reach the skull base, and there's a space within the upper border of the bulla and the skull base, that is a suprabular recess. Is that clear? Okay. Now, what is the supraorbital cell? First of all, you have to understand that the supraorbital cell is a completely different system from the frontal sinus and frontal recess. The supraorbital cell lies just behind the frontal sinus, and it goes laterally over the orbit. Now you know that the frontal sinus is also over the orbit, and supraorbital cell is also over the orbit. So they look very similar, but there is always a partition between the two. There is always a partition, and the supraorbital cell will drain into the suprabular recess. And because it drains behind the anterior wall, so see this is the anterior wall of the bulla. Have a look at this. This is the anterior wall of the bulla. And if you extrapolate it like this, then this is the frontal sinus, but the supraorbital cell will drain behind the anterior wall of the bulla and into the suprabular recess. So the frontal sinus drains into the frontal recess, the supraorbital cell drains into the suprabular recess. The supraorbital cell opening is beyond the anterior wall of the bulla, so it is outside the frontal recess. But because both of them pneumatize over the orbit, on CT scan they look very similar. And like I said yesterday, that the way you will recognize whether a particular cut has gone through the frontal sinus or through the supraorbital cell is whether the anti-ethmoidal artery is seen. Because both the anti-ethmoidal artery and the supraorbital cell lie behind the anterior wall. Yesterday I told you that today I told you that the anti-ethmoidal artery lies outside the frontal. So since both of them lie behind the anterior wall of the bulla, if you can see the anterior artery, then that is not the frontal sinus, it's the supraorbital sinus. Is that clear? Any questions on that? Anyone who hasn't followed